We can start and welcome back after winter holidays in our journal club. And I'm very pleased to welcome Mario Iannaccone and Andrea Montabone from San Giovanni Bosco Hospital, Turin. And the today focus will be percutaneous thrombectomy during acute pulmonary embolism through mechanical thrombectomy, and we will see the results of the FLASH registry. So please write any question or ask any question to our guests after their speech. But first of all, I leave the stage to Andrea to present us the results of the FLASH registry. Thank you.
Okay. Thank you, Julia. I am Andrea Montabone, a fellow in interventional cardiology at San Giovanni Bosco Hospital in Turin. First of all, I would like to thank the organizer for the invitation. As previously said, the argument of this presentation will be the FLASH registry, so the acute outcomes for the few US cohort of this mechanical thrombectomy registry in the setting of pulmonary embolism. First of all, let's take a step back on about what the actual guidelines tells us, in particular the importance of risk stratification in the setting of acute PE. Upon hemodynamic stability, clinical parameters and risk score as PASI or short PASI, right ventricle dysfunction and cardiac troponin levels, patients are stratified in high, intermediate, or low risk. This stratification not only has prognostic values, but guides our treatments. In patients at high risk, so with hemodynamic instability, a perfusion treatment and hemodynamic support is indicated, usually with systemic thrombolysis. If there's a contraindication to thrombolysis or if it fails as bailout strategy, percutaneous catheter-directed treatment should be considered with a level of indication 2A, level of evidence C. As well as in patient at intermediate high risk, systemic thrombolysis should be performed if not contraindicated, and percutaneous treatment should be considered as a bailout strategy or in patient with a contraindication to this kind of treatment. The same indication are reported in this consensus statement by the ESC working group published on recently published on airway intervention. So catheter treatment should be considered in high risk or in intermediate high risk patient as a bailout strategy of systemic thrombolysis, or if this kind of treatment is contraindicated. Many devices were recently developed about catheter treatment of pulmonary embolism, developed and published with a huge amount of literature. All of them revolves around three different kind of strategy. So the thrombus aspiration, mechanical fragmentation of the thrombus, or local thrombolytic injection, variably combined upon the device we chose to use. Let's talk then about the main topic of this journal club, so the results of the FLASH registry. A large registry that enrolled 8,000 patients in 50 different US sites from 2019 to 2021. In this cohort of patients presented with acute pulmonary embolism classified at prevalently classified at intermediate high risk, more than 90%, with a small amount with a high risk PE, less than 8%. Less than 1/3 of this patient had a thrombolytic contraindication. It's important to highlight how more than 25% of them presented at baseline with a depressed cardiac index. In this table, you can see the demographics and clinical presentation of this cohort of patients, quite young, with a mean age of 61 years. Both sex categories were equally represented with a male prevalence of 55%, patient prevalently obese with a mean BMI of 35. As previously said, 1/3 of this patient presented with lytics contraindication, almost 90% of them with a relative contraindication. The risk stratification, as reported, were prevalently with intermediate high risk and a small amount with high risk PE. All of them presented with a right ventricle dysfunction, presented with RV-LV ratio measured than 1, either measured by CTPA or by echo. The procedure were performed with the flow river system, kind of system. Thrombolytic system is performed via a femoral venous large access from 24 to 60 French, and it's comprises with 2 different catheters, one used for mechanical thrombus dislodgement and removal, and one for the thrombus aspiration. In this table, you can see the procedure characteristics. It's outstanding how were reported no major access site complication. The results, a result almost too good to be true with this kind of large catheter. One of the major concerns about mechanical thrombolytic in the setting of PE is the blood loss due to thrombus aspiration and the subsequent anemization of the patient. In this cohort, they reported an estimated blood loss of less than 0.2 liter of blood. After the development and introduction of the flow saver blood return system that allows to return a small amount of blood to the patient, this was utterly reduced to 0.1. These are the safety and mortality outcomes, absolutely outstanding, as major adverse events were reported in 1.8% of the cases, mainly driven by major bleeding. There weren't intraprocedural deaths and a 0.3 all-cause mortality after the first 48 hours, which were adjudicated as not related to the procedure. About the major bleeding, 8 out of 11 cases were due to an hemoglobin drop of more than 5 grams per deciliter. None of these patients had utilized the flow saver blood system. The other cases were due to one retroperitoneal hemorrhage, where the other 2 were due to the need for blood transfusion. In one of these 2 cases, the transfusion were performed after the placement of a bilateral percutaneous nephrostomy. No intracranial hemorrhage occurred. Regarding the right ventricle function and the hemodynamic changes after the procedure, the results are also outstanding, with a significant reduction in the pulmonary artery pressure and the pulmonary vessel resistance. Also, in the subgroup of patients we presented with a low cardiac index after the procedure, we saw an increase in the cardiac output. If we stratified the patient in the level of pulmonary hypertension after the thrombectomy, an improvement was seen for the classes. Regarding the right ventricle function, where a change, an improvement was seen both for the right ventricle ratio and the right ventricle systolic pressure, and an improvement for the right ventricle function in its entire evaluation. Also, the symptoms of the patient were significantly improved with a reduction of the oxygen supplementation need. More than 70% of the patient after the first 48 hours doesn't need oxygen supplementation at all. They were on room air. In the table, you can see the conclusion of these studies. I'd like to focus your attention also on the hospital stays. They were absolutely low. More than 2/3 of the patient doesn't need to stay in a ECU for observation after the procedure, and the meal in hospital stay were of 3 nights. In conclusion, this first large registry about mechanical thrombectomy in a pulmonary embolism setting with the flow trigger system were absolutely good, and as they show a low rates of major adverse event of 1.8%. And with a significant improvement in the hemodynamic parameters of the patient and in the right ventricle function that were also observed immediately after the procedure were performed. Also, a significant reduction in the symptoms of the patient and the need for oxygen supplementation. Obviously, this study due to its pivotal nature, presents many limitations that were discussed later with Dr. Iannaccone. Thanks for your attention.
Thank you very much, Andrea. And please, Mario, could you please explain us the lights and shadows of the paper?
Thank you, Julia, for the floor. Thank you for the invitation, first of all, and great presentation, Andrea. So there are many points that should be analyzed in these studies. There are impressive results that we need to better understand. Beginning from the strength of the study, as Andrea said, there is an important sample size. 800 patients is one of the biggest registries in this field, especially regarding the thrombus aspiration strategy, because most of the registries and published RCT in this field are focused on catheter-directed thrombolysis, while as Andrea said, this registry is focused on an aspiration strategy, in particular with the single device, which is the flow trigger device with a large caliber up to 24 French. The results are terrific. From an hemodynamic point of view, there is a significant reduction of pulmonary artery pressure and an improvement of right to left ratio in terms of diameter. And this is important also to understand which is the endpoint during PE intervention, which is not so clear. We can discuss later, Julia, if you want, but one of the most important points when I perform this kind of procedure is try to understand when to stop. We know during ST elevation mechanical infarction that PE free flow is our endpoint. We don't really know which is our endpoint during this kind of procedure. And another point that has to be underlined is the reduced in-hospital stay. In this kind of patient, the in-hospital stay is at least a week, while, as shown in the registry, most of the patients were in the hospital for 3 days, with 2/3 of the patient without ICU observation. This is really important, also, especially in these periods. However, we have to admit several limitations. Of course, there is an observational single-arm design. Of course, is not randomized. But I think the first measure, the biggest limitation of this registry is related to the study protocol. The rolling time is not well specified in the protocol, and most of the patients were probably included after the procedure. So probably we can imagine an important selection bias with an underestimation of the intraprocedural death and probably also complication. And this may be easily understood also from the baseline characteristics that are not comparable with our real life scenarios. As we know, as recommended from the ECS recommendation, as Andreas shown, in Europe, most of the patients that go to this kind of procedures are patients with contraindication to thrombolysis or anticoagulation and so on. And most of the times are in with massive pulmonary embolism. In this registry, about 80% of the patients were at the intermediate to high risk, and only 10% had an absolute contraindication to thrombolysis, and we have no information at all regarding the anticoagulation contraindication. So we have to really understand that the patient that was treated in the US is not at all the population that we treat in Europe, according to our recommendation. And at least is not my population in particular of our sector. And so the authors showed a really low, zero, if I'm not wrong, zero intraprocedural death and a really low complication rate. That is a really encouraging result, but we have to really take with some doubt this kind of thing. And also we have also a really low 30 days death, and also this is a little bit strange. In fact, we know that most of the patients that have PE have other causes that may have determined this kind of situation, as cancer, as a trauma, as a surgery. So the 30-day death may not be related to the PE itself. Having such a low 30-day death is indirectly correlated, in my opinion, to a selection bias of this kind of patient. So my results, my conclusion is that the FLASH registry results are really encouraging in terms of safety and efficacy, especially in intermediate to high risk population. But however, further studies randomized are needed to really understand the benefit risk ratio of this kind of population, of this kind of procedure in this setting.
Thank you very much. Mario, I have some question. And because I know that you are an expert in this team, in these topics, so I want to ask you, do you perform a thrombectomy with other devices? And so which kind? And do you think that we can choose one device or other regarding a specific patient and the characteristic of the specific patients?
Okay. Thank you for this question. I think this is a really important point. In our institution, we have all the most used device for pulmonary intervention. So we have a catheter-directed thrombolysis device, such as ECOS. We have the FlowTrigger device, and we have also the Penumbra CAT11 device. So we have the opportunity to use both catheter-directed thrombolysis and pulmonary aspiration systems. I think that in this field there is no one-size-fits-all, and the correct devices should be used according to the clinical setting and also the PE anatomy in terms of proximal to mid to peripheral embolism. And also regarding also to clinical setting in terms of hemodynamic decompensation. In my personal opinion, I really like the FlowTrigger device, especially in massive and proximal pulmonary embolism, because it is the strongest system with terrific results in terms of coagulation aspiration. But we have to admit that it may be some limitation if we want to really be aggressive also in segmental and subsegmental arteries. So,
yeah.
If I have to tell you the truth, in massive PE, my first choice is a flow trigger device.
Okay.
In submassive, according to the PE anatomy, we can choose the flow trigger device or the penumbra device. If we are thinking to a catheter direct, a pulmonary aspiration strategy.
Okay, thank you very much. And Rossella asks if you can give us some tips and tricks on how to use the device, what to pay attention to, and mainly when to decide to stop. Because I think that it's an easy to use procedure if you are a right heart catheterization operator, but it's really difficult to decide when to stop.
Yeah. So there are so first advice to perform the flow trigger procedure with flow trigger, in my opinion, is to try to go as deep as possible with the device inside the thrombus to avoid unnecessary blood aspiration. So it is really important, in my opinion, to go deeply with the tip of the device inside the thrombus. If you are deeply in the thrombus, you will not aspirate blood. At least a minimum you will aspirate some blood, but we are really talking of little and not significant aspiration and blood loss. And this is, in my opinion, the most important tips and tricks that I have learned during this kind of procedure. Indeed, the device is really flexible and hydrophilic, so it's not easy at all. It's not difficult at all to get it in the pulmonary artery, of course, on a stiff guide wire, such as amplats or something like this. When to stop? I have experience with this device, with the penumbra device, and also I did in the past some cases the angiojet. And what I really learned from this kind of procedures is that you should stop when you can see an hemodynamic improvement. Each time I take a pulmonary artery main pressure, mean pressure at beginning and at the end, I want to achieve at least 5 to 10 millimeters improvement during the procedure, and also from indirect hemodynamic parameters such as easily from the heart rate. You can see during this kind of procedure patient that arrived in the cath lab really tachycardic, and after the procedure you can see the heart rate going lower than 100, and also increasing in pulmonary in systolic pressure, arterial systolic pressure, and of course, but this need a little bit of experience, the angiographic results that should be not a stent-like results, if you understand what I mean. Yeah. It should be a sort of functional result. So also, if you don't see a perfect result with 100% removal of all the thrombus, but you can see the pulmonary artery periphery, most of the time it's enough, you can stop.
So some practical advice: you use hydrophilic wide to go deeper, and you use stiff wide to push the delivery on, and you use mother and child system.
I use a polymeric wire such as Terumo, for example, to cross the thrombus. Then I exchange with a normal catheter, 5 French catheter or 6 French, doesn't matter. The Terumo hydrophilic with a, normally in my cath lab I use Amplats 1 centimeter stiff guide wire, and then I go for the flow triver aspiration. Of course, I have an introducer sheet in the femoral vein, 24 French.
Do you use a buddy wire or not? You see,
not from the beginning. If I have some difficulties, I may try, but indeed, it never happened.
Okay, I have another question. In case of talking about indication to this practice, in case of failure of systemic thrombolysis, which parameters do you believe most? The hemodynamic parameters of failure, of echocardiographic parameters of failure? What do you think about it?
In my mind, but it's a personal experience, a personal opinion, the PE shock may be certified such as a cardiogenic shock scenario as the SCAI classification. So from my point of view, is a multiparametric decision and may be certified according to the SCAI shock parameters. So
okay,
this is
yes, thank you very much. And after the procedure, do you use any evaluation of the cardiac output in ICU as PICO or something else to monitoring the hemodynamic improvement or not?
Generally, for PE, no.
Okay.
I mean, there is a thrombosis in the pulmonary artery, so to leave as one guns there maybe not optimal. You can use indirect system, of course. They may be useful, but indeed the right recovery, as we can see during the inferior ST elevation myocardial infarction, most of the time is really fast. Yeah. So you can, once you see an improvement of the hemodynamics during the procedure or at the end of the procedure, in my experience, I've never had any kind of worsening of the clinical situation.
And finally, talking about endpoints of future study, what do you believe we should evaluate in the outcomes of these kind of patients?
This is an important question. Not an easy question at all. I think that the studies should look at clinical results, and the clinical results in terms of death, of course, but also something that is not clear from my point of view is the non-acute pulmonary hypertension related to acute PE. It is unclear for me, at least, which is the rate of patients that may benefit from this kind of procedure, not in the acute setting, because they may be managed also with the medical therapy, but the rate of patients that may benefit in long term because of the reduction of long-term pulmonary pressure and the long-term development of pulmonary hypertension. So acute setting MACE, death and complication, long-term in terms of development of pulmonary hypertension.
Thank you very much, Mario. If anybody has any other question, I think that it's time for us to turn back to our...
Hello, I just
hi, Evelina, thank you.
Hi. Great presentation, and thank you very much for your nice insights. So my question is more practical, because I work in a center that has the emergency department, and we do 24/7 cath lab, but we do not have a catheter-based system for the treatment of pulmonary embolism. Actually, it's not that common to have patients that potentially need an intervention, but at the same time, sometimes I feel that I would like to have that treatment in my portfolio. So in your opinion, I know you have a lot of devices in your cath lab, and you have experience. Do you think it's more appropriate, considering, for example, the region of Lombardy? In Italy, we have a lot of cath labs, but not all of the cath labs have these devices. So do you think it's more appropriate to have a sort of PE network like the STEMI network, or any cath lab that can perform interventions in emergency should have at least one device for the PE treatment? Because of course, the sooner you do the intervention, the best outcomes you potentially may achieve, but it's not in terms of 1 hour. So you may have time for moving the patient to another center, or do you think it's not that impossible to be performed from a standard operator, so any cath lab should have a device? So I would like to hear your opinion.
This is also another important point, and it's really hard to answer in a small time. So it depends on the clinical setting. I mean, if you have massive pulmonary embolism, the patient most of the time cannot be transferred from an hospital to another. So there you have two options in this setting. First option is to try by yourself and try to do the best you can. Second option is to activate an ECMO team that comes there, place the ECMO, and transfer the patient on support to a secondary center, hub center, that may do the procedure. Not easy at all. These kind of networks are improving in Italy, but is not the standard at the moment. And this is a situation. Second situation is the stable patient that may benefit from an interventional procedure, but is stable, and this patient may be transferred to another center, and this setting is much easier, and you can manage it easier with a spoke center, with another hub center. In my opinion, there are some kind of pulmonary intervention that are not so difficult to perform for any interventional cardiologist. So probably you can start from the easier procedures such as catheter-directed thrombolysis, and then move a step forward to thrombus aspiration.
Thank you very much.
For example, Evelina, because we believe that this is a very important question. In Padua, for example, we are starting with an internal regulatory plan, a PDTA, to try to formalize all these procedure. And because we have to coordinate us with the emergency department, the ICU, and I think that we should start to think about to all this procedure.
Yes, because I think
also during the night.
But actually, you have the possibility to reperfuse the lung. So, of course, this study has several limitations, but it's impressive what they published. So, especially for younger patients, or those with a contraindication for thrombolysis, I think it's something that we should work on as interventionalists, because we can potentially give a better treatment with the catheter-based devices. So I also believe that we should improve that. So I'm happy that you agree.
And it's very terrific results, as Mario said, in practice, in real life.
Yeah.
So thank you very much to everybody. Thank you, Andrea. Thank you, Mario. Great presentation, great discussion. I leave you for tonight, but next appointment will be on 25 of January, 25 of January. And Professor Baumbach will join us from London. So I'll keep you posted, and we will see on next Wednesday and next Journal Club. Thank you very much.
Thank you very much. Bye-bye.
Bye.